Rayid, welcome to the show.
Thank you.
So, pleasure to speak with you, and glad that we were able to connect. I'm so curious that I was, when we the way I read about some of the things that you've done was, of course, in you were seemed to be the focal point or the center point of the Obama campaign and how they understood how to utilize AI, ML, and different analytical approaches to understand voter sentiment and how to understand how people were, thinking about things and how they might vote in the future. And it'd be interesting to hear, first of all, a little bit of your background, obviously, for everybody that's listening, and then a little bit about that project, which I'm sure you've talked about many, many times over by now.
Yeah, well, so before we go further, focal point is extremely exaggerated, but I think my role. So my background is traditionally computer science, machine learning before it was trendy, and before it was you could tell people you do without getting blank stares. But that's what I did in grad school, and what got me really excited about this area was, I wasn't one of those kids who I loved programming since I was 7, right? Coding. I hated coding. I thought it was pointless. I thought computers were supposed to be smart. And then I realized the computers are really dumb and you have to tell them exactly what to do, how to do it. By that time, you might as well just do it yourself. So when I kind of encountered machine learning and AI, it sort of opened up an area which says, well, yes, computers are really stupid and dumb, but we don't have to tell them exactly what to do. We can tell them the rules of the game and they can play the game and adapt and get better as the world goes on. And I think for me, that was the piece which got me to thinking about how do I go from there to using these technologies to solve real problems. The 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 Obama campaign was one of those massive challenges, massive organizations where people talk about it as a startup, and well, it was a startup with all the problems of a legacy organization. Old databases, siloed data, lots of people doing things in person, so door knocks, phone calls, millions of volunteers, and the challenge was how do we integrate all of this, combine it, analyze it, and then inform these actions where who should be prioritized for voter turnout, who should be persuaded, who should be registered to vote, who should be asked for money. And sort of a lot of my role was to take the things that were happening in the private sector around these efforts and or coming from academia, newer techniques, newer methods of machine learning, and see how do we apply these to the campaigning world, which hadn't caught up to those types of things. And the idea there was really, very much one of the things that the marketing world talks about a lot is, micro targeting and one-to-one and individual. And that was a thing that political campaigns had figured out a long time ago, because all the outreach was individual. All the door knocks and the phone calls were not mass targeted or segmentation. It was all individual. What was lacking often was the analytics behind it that would inform those individual interactions, that the interactions existed, which is the opposite of a lot of the marketing and retail world, where you had the data to figure this out, but not the outreach in store at the point of purchase and things like that. So a lot of the idea was how do we use machine learning and social networks and combine that with behavioral psychology, persuasion type methods to see, it's not about just about predicting who's going to vote or not vote or donate or volunteer, but coupling that with persuading. How do we persuade them? How do we change the outcome that we care about? Because it wasn't an exercise in trying to just predict and then watch things happen. It was an exercise in changing the outcomes.
Well, that sounds like almost like, especially at the time you're talking about, kid in a candy store playing with, and seeing almost in real time what the effects were. And that must have been quite interesting.
It was, and I think the it would have been a kid in a candy store if you had unlimited time to explore. But one of the things about a campaign is that you have a very real deadline, which I don't think I've ever had in any other job before. You know, you always have sort of, well, we'll do better next time. And the second thing is you have a binary outcome. It's not, oh, we can, you know, we did well. It's you win or you lose, and there's a very real deadline, which means
Right.
that all your efforts kind of have to be targeted towards winning. And sometimes you have to sacrifice those exploratory things that are, well, it'll be interesting to see what we can do there, because you just don't have the opportunity to explore those things. What's sort of unique about a campaign also is that you've got pretty fast cycles, right? So you're getting data regularly, but you're doing analysis and you're making recommendations about what to do, and then you're collecting data again to figure out what changed. So you're
Right.
polling, you know, for the rest of the world, polling is kind of telling them who's winning, who's losing. For a campaign, polling is basically a resource allocation tool where they're trying to figure out, we did this last week. What was the impact of that? And how do we change that allocation next week? And how do we iterate? Which is very similar to a lot of other areas we work on, right? I think the urgency makes it all much more intense and helps you focus on a specific goal. Whereas in you know, that should be the strategy in regular government, in public medicine, where you're doing exactly this, but I think we get distracted because we've got time sometimes.
Well, I think that, you know, to sort of start slanting towards healthcare is, you know, everybody always tells me, like, you don't understand, it's complicated. And, you know, getting people to do things and so on and so forth. And I'm like, I know it's complicated. I mean, I try to manage my own health and I realize like all the little voices in my head and how complicated it is. But I know I can be influenced. I know other people can be influenced. You know, Marlboro did a great job for years influencing people with the Marlboro Man. So there's a way to get people to move in a particular direction. I don't think you'll get 100%,
Right.
but you can get a lot of people. So now, you know, the Obama campaign gave you a lot of sort of real on the ground tech, you know, experience. And so now I know you're at Carnegie Mellon, and you're experimenting with a lot of the same tools and techniques, obviously more advanced at this point, but utilizing it for community outreach and healthcare and making a difference to, I'm going to call, you know, the average person or the masses out there. Tell me a little bit about how you think these technologies can make a big difference in the world of healthcare or just general health.
Right. So I think for me, the aha moment was really during the campaign. Sort of what one of the lessons learned was really, if you can have this coordinated organization where you have data about people, you're making these recommendations and people are acting on them, and then you're testing what works and what doesn't work, and if you can mobilize people to achieve sort of these, you know, goals of winning elections and winning campaigns, why not do the same thing for issues that are sort of much broader, that affect everyone, where they're probably, some of them are even less controversial than a lot of political candidates. And so the last sort of several years, about 7-8 years or so, what I've been focused on, first at University of Chicago and then at Carnegie Mellon, is to see, can we apply these technologies, machine learning, AI, all the buzzwords that are now, you know, all too common, towards improving public health, criminal justice, education, workforce development, economic development. And I think that the idea is really simple, right? In general, a lot of the things we do in health tend to be, you know, we do fairly macro things. We make very macro policies around, everybody should get this X. And I think everybody should get this vaccine. Well, that's great. That's the outcome we want. but often you don't have enough resources to make sure that that happens. Ideally we would have the resources so that we go convince everyone, we figure out the right person to convince each person using the right message, but that doesn't happen. So then we have two options. Either we focus on the people who need that help the most, who are more at risk of a specific disease or a specific virus, or we figure out what is the right thing that would work for each individual, each person, right? So for example, if we're, one of the things that we started doing a few years back in Chicago was working with the health department on lead poisoning. Lead poisoning is horrible. It affects way too many children. It has pretty much permanent damage that cannot be reversed, except our government. So we know that this has irreversible damage. There's nothing you can do once somebody's has had high levels of lead in their blood. The most common tactic that's used by governments is waiting until somebody gets lead poisoning and then fixing things after that. So we know that nothing can fix it, yet we still go and do reactive things. And why do we do that? Because of pure efficiency reasons. Because, well, we can't fix every home. That's going to be too expensive. So the way we prioritize is we find kids who have been poisoned, fix their home so that the future kids in that house don't get poisoned. Which is, there's some impact, but the impact on the kid you're trying, who just got tested positive or high levels of lead, that's almost zero, right? So that's pretty common in, we have a lot of reactive policies. We wait until something goes wrong.
And it ends up costing you more. I mean,
That's
because that kid is not going to be a productive member of society at the same level that they would have without the exposure.
That's right. That kid is gonna, is gonna have pretty bad outcomes. Their family is going to be affected. The community is going to be affected. Generally, a lot of these things happen in clusters, right? So entire communities get affected.
But this is like everything in healthcare, right? Healthcare is historically has been reactive. You get sick, you go to the doctor and they manage you. But I think technology now is giving us the ability to get ahead of some of these things.
Right, and I think that's the goal is that there's sort of two things we need to figure out. Right, one is we need to figure out who do we prioritize, because we don't have resources to prioritize everyone as much as we want to, and so that question is a difficult question depending on your societal values. Do we prioritize people who are most at risk of lead poisoning? Do we prioritize people who most need the help and will not make it otherwise? Do we prioritize people who are easiest and cheapest to help? Do we prioritize people who traditionally have had other issues and this would make it much worse? So that's one, is can we figure out who is at risk? Can we predict proactively who needs that help? Who do we prioritize? The second thing in many problems is how do we actually convince them to actually change the outcome, right? In the lead poisoning case, it's a little bit easier because we can remove the source of lead and that takes care of the problem. But if we're looking at diabetes, it's another project we're doing with a hospital, a clinic system in Chicago, was identifying people who might be at risk of type 2 diabetes. And there, yes, you can identify the people with pretty high likelihood, pretty accurately. And same going back to the voting case, predicting who's not going to vote is not that hard, or predicting who's not going to vote for us, for a candidate, is not that hard. The question is, how do we persuade them to vote for us? And how do we persuade them to change their lifestyle to not get type 2 diabetes? And so those are the two things that we need to couple together, is not just prediction, but prediction combined with behavior change. And that requires both sort of the data about these individuals, but more importantly, it sort of creates ethical issues around how do we test these ideas? How do we test persuading somebody to see whether they get persuaded?
But that's interesting, right? So I would, just from the advertising agencies, from historical marketing, credit score data that on how people react and so on. There must be like a ton of data out there on, you know, when we did Y, we saw X, and when we did Z, we saw B, and different testing, because I would assume that all the marketers have been doing this since they gathered their first piece of data, right? Back, I don't know, go as far back as you can.
You would think so. This is one of those things which rarely gets collected as data. What is collected is what happened. What's collected is what did they buy, right? So what we typically know is who gets diabetes and who doesn't. What we know is who bought a product and who didn't. What we don't often collect very well and test is what got them to buy that, or what did the physician try to get them to do to change their behavior, and what was done when, and what was the outcome, right? We typically see results, we typically see outcomes, we see fatalities, we see diagnosis. So most hospital EMR data, claims data, has diagnosis codes and procedure codes. It doesn't have, oh, the doctor gave them this intervention, they gave them this advice, here's what they said, in which they said, I'm not going to do this. Or they asked them, have you been doing this? Like, oh no, I haven't been working out, I haven't been going, and I haven't changed my all that data doesn't really get captured in most cases. And same for marketing. In most marketing things that have been done, there's a whole set of tactics in behavioral psychology that exist to sort of persuade people, right? Things like social proof and we generally know that those things have an impact. What we don't know is what types of impact, what types of those tactics work for what types of people, for what types of behaviors. That's sort of the taxonomy that we need in order to say, okay, we're trying to help people change to get employment or to change their health outcomes. For this person, the best thing to do is for their family members to tell them about how they did something similar and things changed for them. Like if we knew that, then we could one, test that, but we could then deploy that. But that also comes with, again, the ethical issues around these types of things is who decides what that is? Who decides that we are able to test with that, test that idea? And then who decides that is beneficial for them? And then how do we involve that community into that? How do we involve the people who are being affected into this process?
But okay, so I mean, there have been paper, like Geisinger has done, they wrote a paper of what they were going to do and then what the outcome of it was. And I've talked to Glenn Steele about this as part of my book. And, you know, they put in a monitoring system for their type 2 diabetes population. Right. And the nurses actively interacted with that population to be able to, you know, gain or help manage those patients to have a better outcome, right? And then the doctors got raised up to manage the harder patients, right? And they saw, I can't remember if it was some 23 to 25% decrease in comorbidities, right? So you have this captive data set of 35,000 people, which is not small.
Yeah.
So, you know, somebody's done the experiment.
Yeah.
So couldn't you start to use that core data set to drive, you know, what you would do next to do, say, broader influencing?
Yeah, you could, right? So I think a couple of things there. I'm not familiar with the study, so I don't know what the population is. I don't know how representative.
I'll send you a copy of the paper.
But with all those caveats, right? It's yes, if somebody's done this on a I'd say small number of people, 35,000. It's large for a study, but small compared to the type of number of people who we're trying to influence. I think step one would be to sort of see, well, how well does it generalize to different populations? Because often these studies, typically, so type 2 diabetes is one where it disproportionately affects minorities.
Right.
And so if the study that was done had the underrepresented people were also the people who had disproportionate, disparities in there, then we have to kind of figure out how well does it generalize to people of different types. Were those persuasion tactics done, were those influence done through digital channels or in-person channels? If it's digital, do they have access to those types of devices that they're using? If it's in person, do the people who were really trying to impact and to influence, is it accessible to them? Can they come in person to these types of things? All of those, so I think step one is to really, if we know that study worked, the second piece would be to figure out how to test and see how does it generalize to the larger population. Does it result in kind of fair and equitable outcomes for everyone rather than the typically, the white males, or in this case, I'm not sure what study was, right? And if that's if it does generalize, then you're absolutely right. I think we can start sort of defining community programs that involve the communities that are being affected and design, okay, here's what we're trying to do. Here's our overall goal. We want to reach equitable reduction in type 2 diabetes in this community. Here's a trial we're running. We're going to identify these people. We're going to, try to change their behavior. We'll use the community and the community health workers and the nurses and the physicians to put this program together. Now, what we still need to figure out, one challenge that comes in is we often run into this lack of resources issue, right? In which case, then we have to triage. And that's where we need the data to, we can't try everything with everyone.
Right.
And so if you could only try one thing, which one thing should it be? That's where the collected data is really helpful. And that's where we have to collect the data also in the right way, right? If you only tried one thing with people, you don't know the counterfactual. You don't know what would have happened if you tried something else. And so if it was not done as an experiment, then all we know is this person responded or did not respond to this tactic. What we don't know is what would have happened if we had tried a different tactic. Would it have been better? Or would it have been worse?
Wouldn't you just love it if the system could play and eventually say, here are the top 3 ways that seem to get the outcome that you're looking for, and then implement those?
Yes, except each turn in this play could cost somebody's life, right? So what you want to figure out is really look. So let's say you tried this person. We're gonna try to change their physical, walking behavior, and we tried a tactic that I'm not sure if it's gonna work, but it didn't work. That person ended up getting type 2 diabetes, and if you had only tried it, if they were in the group B, it would have worked out fine for them and they would have changed their behavior. And so the question really is, well, how do you do it ethically? But I think that the other question is, how do you do this with lower risk outcomes, right? Can you figure out a way to generalize from kind of small things so that you don't have to go and test with the high risk situations?
Yeah, I was going to say, I mean, could you pick things that have a lower impact, but human nature, you could sort of get an idea of what buttons to push.
That's right.
And then raise the bar when you move to the next level.
Exactly. So I mean, for example, if one of the big things in a lot of these things is sort of adherence, right? Is do people, and you have a bunch of different, you can do reminders, you can do sort of social proof type things, you can have a bunch of other tactics, and so you could try this out with lower stakes outcomes, and then you still want to test and see. So the large number of people, the trials you run can be with the lower stakes outcomes, and then the smaller number, once you figure out some of those things, we still have to figure out whether it works for people for the outcomes that we care about. And I think that's where the more we can do coordinated trials and studies across, right? They're going to be, that's I think where, and sharing data across them all. I think that's one that we don't do very often, is we'll share results, but we don't share a lot of the original data that was collected as part of these types of trials.
Actually, it was interesting because I was talking to somebody this morning from Takeda, and we were actually talking about that exact same thing of everybody holds on to their data. Or if they give you their data, they didn't give you the metadata.
Right.
right? So it's less valuable than if it had the metadata with it. And it, that for some of these things, especially in the healthcare arena, we have to figure out a way around that.
That's right. I mean, we have to figure out a way to share that we tried this thing with this person and it worked or didn't work. Instead, what we share is 24% improvement in reduction in diabetes. Well, that's great that on average you improve 24%, but maybe for 10% of the people, it really hurt them. For 50%, it improved 5%, and for the rest, it improved quite a bit. And so if you had that data, you could say, well, these 10%, don't try this intervention with them because it'll make their outcomes worse. So I think, and again, that's coming, what we started with elections, in 2012 campaign, that was one of the things we learned is we ran these experiments to persuade people to vote for Obama. And then we measured their change in support for Obama after the persuasion. And we found that, some people became more supportive after somebody went and talked to them. Some people kind of kept the same. But then we found people who were negatively persuaded. And those were the people at that time we said, well, no, don't talk to them. Nobody should talk to them, because if we talk to them, they're going to start going against us. Now, that's a political campaign, so we don't need to convince everyone to vote for us.
Correct.
So not talking to them is fine. But in a health situation, we have to figure out what else can we do? What are the other types of interventions we have that are positive for these people, and identifying them and focusing on them. And that's where I think a lot of research and foundations can put money in identifying gaps. Like, who are we leaving behind today? Our interventions are measured right now at, the effectiveness is at a macro scale, right? 10% effective, 20%, 30%. We need to go much more finer grain and say, well, for these types of people, it's this much. For these types of people, it's this much. For these types of people, it didn't do anything. So let's now focus on those people who are being left behind, because we can't just live with averages, forever.
So now fast forward, right? Obama campaign, now we're moving forward to today. Technology has moved a lot faster. The chipsets we have now are orders of magnitude more sophisticated. The software has gotten better. Cloud computing has gotten more abundant and cheaper. Where do you see this technology, these capabilities going, and the impact it having on health and health outcomes? Because if we're moving to a value-based payment system, this direction has to become front and center for every healthcare system. Otherwise, they're not going to be able to achieve their goals.
Right, and I think that's a good point, right? So I think the technology has existed for a while. It's not as if 6 months ago, 2 years ago, 5 years ago, all of a sudden technology changed, so now we can do value-based healthcare. At some level, the technology has existed. It's better now. It's that there's more data. Their computers are faster. I think the issues have more been organizational and political than technical. And so right now, what's required to kind of figure out value-based, payments and value-based healthcare? It's really what's the cost of this person if I don't do anything, and how much will it cost me to prevent? Like, it's fairly straightforward. I'm doing this calculation, which actuaries have been doing for a long time, right?
Right.
What are the risks associated with this person if I don't do anything in my community? Because I'm responsible for this entire set of people. Here is the cost. And then what can I do now that's preventative that will reduce that cost? And then going on and executing on that, right? So I think if we put these types of, I'd say, regulations in place, really, because that's, I think, what's really needed is you have to achieve these goals, and these goals have to be not average. On average, you have to spend this money. It's more, I think, today a lot of these payment systems are not focused on equity. They're focused on kind of average. Like, we're going to give you $5,000 per person.
Right.
you want to say is, no, 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 no. I'm not going to give you $5,000 a person and you do whatever you want with it. I'm going to give you this much money for this, but your goals should be that everybody ends up with equitable, equal risk of type 2 diabetes, for example. Right? And that's a very different framing, because with the $5,000, what you might do is take the 10 highest risk people who you can easily change and go after them and say, look, I'm done. That doesn't get to equity. So I think what's missing from the value-based healthcare, it's not the technology right now, is sort of a little bit more fine-grained thinking around how do you turn that into equity-focused value-based payment and value-based healthcare. And then that's kind of on the goals side, right? So what are your goals? What are you designing? Second thing is, do you have the right data? Do you have the data? And I think that requires data sharing across both hospitals, health departments, pharmacies, pharmaceuticals, because each of those have different data that's useful. And we don't have a good way of sharing this in a way that's both protects people's privacy, but still is actionable. If it's anonymous, it's not actionable. If it's totally open, then it's too risky. So we kind of need to figure out data sharing practices that are not difficult. I think it's just needs to be done. And then we need the analytical infrastructure in place to be able to combine that data, figure out who are the people actually at risk, figure out what's going to change their behavior, and then an experimental infrastructure to actually run these tests and see what works. Micro test, right? We're not doing massive changes. We're testing things continuously because things are going to change over time. So with the right goals in mind, with the right data infrastructure, the analytics, the experimentation, and very much a community-based design, I think that's the system we need in order to truly do sort of equitable value-based healthcare.
So do you have any examples of any of the things that you've done that because you speak as if like you're talking about a very, specific experience as opposed to something in general?
Well, I've done pieces of it. So that's the challenge with doing projects with an organization, that when I'm working, so I work a lot with government agencies and I work some hospitals, and you can only do one piece, right? And that one piece, so the part that we focus on a lot is how do we come up with these sort of goals, and how do we combine the goals of efficiency and equity and effectiveness, design a system that's able to get this data and run these types of models. So I'll give you one example. It's somewhat it's a health space, but it's kind of criminal justice and health. So there's a project we've been doing for a few years with a county in Kansas called Johnson County. So the border of Missouri and Kansas. And they, like many other places in the US, many other places that they have a recidivism problem in their jails, right? So huge incarceration rates. And one of the root causes, which is unmet mental health needs. So a lot of people who have mental health needs, and the outcome is they end up cycling through jails. And so in their case, they decided, look, we've got some resources to proactively. So right now, they had a team that was a mental health outreach team. What they would do is when somebody would get released from jail, they would try to contact this person in the first few days to sort of see if they needed any support, any help. And that was just a routine thing. And that wasn't resulting in any reduction. So they came to us and said, we have some extra capacity. We want to be able to try out doing outreach to a couple hundred people a month to see if we can provide them with mental health services. And our goal is to reduce recidivism. So we sort of work with them to kind of figure out what are the overall goals. We want to make sure that we use these resources efficiently, but we also use them to effectively reduce the recidivism rate, but to also make sure that it's being reduced in an equitable way. So if we only focused on people who were cheapest or easiest to help, we leave people behind. So we want to make sure it's not doing that. It's not increasing disparities. And so step one was sort of trying to figure out these goals. Step two was, what data do we need for this? Well, we need data from the jail system, obviously, who's coming in and going out, but that's not enough. We need data from mental health services to figure out who's had encounters with mental health. But that's not enough because they might not be going to mental health, they might be going to emergency department, and so we need data from, ER and 911 calls, or we might admit the other criminal justice things going on with the police, so we need data from the police. So we sort of work with the county to get access to all of this data, and they did an amazing job of sort of pulling all these things together. So now we kind of see a person across these systems, and we can then build the analytical infrastructure to predict what's the risk of this person coming back to jail. And we can now look at their historical mental health history and see that they have mental health needs and they're high risk of recidivism. And we find that actually we can pretty accurately predict who's going to be coming back to jail, which is fine and a good first step, right? But that's not enough. Like, now we can figure out who we need to help. The question is, can we help them? So we actually started a trial about 12 months ago with this county, where we're giving them a list. They're going out and doing this mental health outreach to that set of people. And then we're getting this data back to measure two things. One, is it actually reducing their recidivism rates? Because that's the whole point. If you predict them and watch them go to jail, that's horrible and depressing. And so that's one. Second thing that we're testing is what I was mentioning about the healthcare world also is what types of people is this intervention working with, and what types of people is it not working with? So that when we actually implement it after the trial, this intervention goes towards people who it's more likely to help, and the new interventions get designed for people who it's leaving behind. So that trial is just finishing now. And over the next 12 months, we're going to be getting this data back to measure how many people actually come back to jail in the next 12 months compared to the ones, based on the people they intervened on versus the people that they didn't have capacity to intervene on. So that's an example of a much, much, much smaller scale system, still an ambitious big problem, but we're kind of tackling a small piece of it, saying, can we take the people who have unmet mental health needs? Can we identify which of them are at risk of recidivism? Can we intervene and see if this intervention is effective? And if it is, then we can implement that type of a program and iterate on who it's not working on. So we'll find out over the next 12 months, if it works. How it works.
And the sneak peek, do you know if it worked?
Don't know, right? Because it's one of those things where two reasons. One is they've been doing this for the last 12 months. So now we're going to start for the first month. Basically the idea is, if the people they intervened on 12 months ago, how many of them have come back to jail in the last year, right? So in 1 month, they only intervened a couple of hundred people, 150 people. And so we don't have enough numbers to know until 12 months have passed to find out. And so right now, I just have, it's one of those things where you just don't know it all. And then especially given the COVID situation the last few months, that's going to be mixed up in there. So we're going to have to figure out how to tease that apart and figure out, the effectiveness of this. But that's just comes along with, doing these live trials.
Yeah, no. It's extremely complicated. But I actually believe the technology is getting better. I think we're understanding how to do these things better. I think depending on the disease, sensor systems are getting better, cheaper, so you can monitor things over a longer period of time. So I just see this, if implemented properly, and people actually pay attention to the data, that you could move the ball forward faster. It's just getting this distributed to more systems once you prove that it works. And that's the part that I always have issues with. Like, one group, one place did it, and everywhere else says, well, we haven't done it. Our population is different. And they don't pay attention to the study, and they don't implement it themselves, which makes it difficult to have a broad nationwide impact on healthcare.
Absolutely. I mean, everyone thinks they're special, and turns out all of us are not that special. Most of us are not that special. People who we know, and similar tactics work on on all of us. So I think if we and that's the thing. And I think that as you were talking about, the being able to coordinate these types of tests and these trials to make sure that they're representative of different populations, so that when we get results, we can say, look, it's worked on these types of people, didn't work on these types of people. So the next one, go focus on these, verify this, and investigate this. Right? Like
Right.
It just needs
I mean,
to
it would be, you'd constantly be able to make it better if we had some sort of process of doing that.
exactly, because we don't have to start from random. We can start from what we know works and adapt from there, as opposed to start from
Yes.
scratch. Well, anything could work. So let's try everything, as opposed to, well, this is the current best approach. Let's start from there and then adapt from there.
Yeah, I hate saying it, but sometimes you almost wish this was centralized.
I think it should be centralized. I think that's where, I mean, this is an interesting piece, because a lot of this is being done by pharmaceuticals independently. But in a world where we had a more, if we had a better centralized, I'm not gonna call it an FDA, but some other body that could sort of have incentives for some sort of centralization, right? Because overall, I mean, that's the problem. It's globally better, but it may not be locally better for each pharmaceutical based on their their own business goals. And so the question is, how do we align those business goals with the global social goals?
No, I agree. I mean, the more and more I look at where this is going, the more you can centralize different data sources, the more testing you can do, the more refinement you can do, and therefore the more impact that it will have in the long run on a broader level of people.
Right. That's the hope.
So, well, it was great to talk to you. I really appreciate your time. I hope that all your work turns out positively, although that's impossible when you're doing experiments like this, but one can hope for the best.
That's right. That's right. Hopefully we'll learn something, and hopefully, it's going to result in something better in the future.
Excellent. Great talking to you.
Talking to you as well. Thanks.
Thanks.